ductal carcinoma in situ, carcinoma, cancer, breast cancer. Get it out. Get it out. If that is where you are right now, I hear you. That visceral, panicked, get it out of me response is one of the most common things I see in my clinic. A woman sits across from me, pathology report in hand, and her whole body is saying, I don't care what any of this means, I just need it gone. And I understand that completely. The word carcinoma, it's in its name. It says cancer. Of course, your instinct is to treat it like a fire and put it out immediately. But this is what you need to hear right now before anything else. You have time. DCIS is not a medical emergency. To have a treatment is not a decision that needs to be made today or this week. In this video, I'm going to give you the full picture. What actually happens next, step by step. What appointments you need, what questions to ask, what your options are, and how to walk in every part of the process feeling clear and in control rather than terrified. By the end of this video, the spinning will have slowed. I promise. I'm Dr. Alex Popadich, breast surgeon, and I have treated multiple women for DCIS over the last 15 years. If you haven't watched videos 1 and 2 of what DCIS is and whether you really need treatment, I encourage you to go back and watch those first. The links are in the description below. They'll give you the foundation on everything we'll cover here. But if you just got your diagnosis and you need a practical roadmap right now, watch this video with me. Let me start with the first 48 hours after your diagnosis, because this is when most of the unhelpful things happen. And I want to give you a better plan. Do not spend the next 2 days on Google. I know that feels impossible. The urge to research is completely natural. But the internet doesn't know your information. It doesn't know your grade. It doesn't know your size. It does not know your age or your health or your circumstances. And it will most likely serve you the most frightening end of every statistic it can find. Also, do not tell everyone immediately. You don't have to. Give yourself 24 or 48 hours to absorb the diagnosis before you start managing other people's reactions. Because your energy right now belongs to you. And don't make any treatment decision yet. You don't have enough information. And no decision needs to be made today or this week. And anyone who tells you otherwise is wrong. In New Zealand and Australia, you will be referred to a breast surgeon who will be treating you following your DCIS diagnosis. If you were diagnosed through BreastScreen, the national screening program here in New Zealand, you may have been told the diagnosis by a surgeon and also brief options of your treatment. Also, you have been referred to a breast surgeon either in public or private clinic. Either way, a referral to a breast surgeon should be the immediate next step. In New Zealand, the public wait times can vary quite significantly by different district health boards. And if the wait times are prolonged, it is appropriate to ask about private options. Ask your GP or the breast screening clinic for a copy of your biopsy report. You're entitled to this. Read it, even if you don't understand it yet. By the end of this video, you will know what the key terms mean, and having it in front of you at your surgical appointment will make conversation more productive. Also, identify one person, a partner, friend, a family member, who can come with you to your first surgical appointment. It's not to make decisions for you. It's just to be an extra set of ears and to help you remember what was said. Your first appointment with a breast surgeon is the most important conversation in this whole process. Your surgeon will look at your mammogram and any other imaging that you may have had. He or she will read your biopsy report in detail. Your breast surgeon will ask you about medical history, your family history, especially of any breast cancers, prostate cancers, or any other cancers, and then your personal medical history as well as your personal circumstances. What we as breast surgeons are doing, we're actually building a picture of you, not just of your diagnosis, not just of DCIS. And in some cases, particularly if you have dense breast tissue, or if the size, which we call the extent of DCIS, is unclear from your mammogram, your surgeon may recommend an MRI or a contrast mammogram. This doesn't mean anything horrible. It shouldn't be alarming you. It's just about making sure the full picture is understood before any surgical planning begins. The next step that we discuss is your grade and what it means for your specific risk. This is a single most important piece of information. If your surgeon doesn't mention grade, ask about it directly. You need to know whether you have high grade or low grade DCIS. The next is the size or the extent of your DCIS. How large an area in your breast is involved, and whether it appears to be in one location or in multiple locations within your breast. And then we discuss surgical options. Lumpectomy or wide local excision versus mastectomy, which is removal of the whole breast tissue, and what that recommendation is for your specific situation. Also ask a surgeon to explain what would determine one option over the other. So, why should I have lumpectomy or mastectomy? Is any of them better for me? The surgeon should discuss how likely is radiation that would be recommended after surgery, and if so, what the logistic of that would look like, where it would be delivered, possibly over how long period of time. In the USA and UK, those surgeons might discuss whether DCIS is hormone receptor positive and whether endocrine therapy like tamoxifen or aromatase inhibitor is being considered. For us in New Zealand and Australia, we do not use routine hormone receptor testing of DCIS because we do not recommend endocrine therapy for DCIS as a standard practice. So if you're in New Zealand or Australia, your surgeon may not raise this at all, and that is appropriate for our clinical context. But if you have been reading American sources and are expecting this conversation, it is worth to ask this question and to flag that practice actually differs here. And then lately, whether active surveillance has been considered for your situation, and if not, why not? This is only relevant if you have low grade or intermediate grade DCIS. Your surgeon should explain that active surveillance is not yet standard practice for treatment of low grade or intermediate grade DCIS. You shouldn't feel that you have to accept the first treatment plan offered without understanding all of your options. So you should leave your appointment with your breast surgeon with a clear understanding of your grade, your size, and what surgical option is being recommended and why. And you should have a follow-up appointment or a plan, either a date of surgery or a next clear step, such as further imaging. You should also leave with a sense that your questions were heard and answered. If you leave the appointment feeling more confused, than when you arrived, it is completely reasonable to ask for clarification, to request written information, or to seek a second opinion. Second opinions are completely normal. They're not an insult to us as surgeons. They're part of informed decision making for a diagnosis, especially in this situation. Let me walk through the treatment options clearly, because understanding what each one involves will help you have a much better conversation with your surgeon. Option 1, lumpectomy or breast conserving surgery. A lumpectomy removes an area of DCIS plus a margin of surrounding normal tissue. The goal is to achieve clear margins, meaning no DCIS cells at the edge of what was removed. The breast is preserved. Before I talk about radiation and when I actually recommend it, I want to mention a tool that many breast surgeons use to help make that decision, because you may hear your surgeon refer to it. It is called Van Nooy's Prognostic Index, or VNPI. It takes 4 things about your specific DCIS: the size of it, how wide the margins are after surgery, the grade, whether there was any comedonecrosis, which is cells dying in the area, as well as your age, and combines them into a score between 4 and 12. A low score between 4 and 6 suggests that excision alone might be sufficient, meaning you just need lumpectomy, no radiation. Middle score 7 to 9 is where radiation is typically recommended on top of surgery. And a high score 10 to 12 points towards mastectomy, because the recurrence risk is high enough that radiation alone wouldn't adequately reduce it. We in New Zealand and Australia use this scoring system more consistently than in many other countries. Over 70% of DCIS cases here are managed with reference to it, compared to less in UK or America. The VNPI is a useful starting point, but it is not a fixed formula. So in most cases, lumpectomy for DCIS is followed by radiation therapy to remaining breast tissue. And this is not because the DCIS has spread. It hasn't. It is to reduce the risk of DCIS coming back in that same breast. Without radiation after lumpectomy, the recurrence risk is around 25 to 30% over 10 years. With radiation, that drops down to around 15%. Lumpectomy is appropriate when DCIS is localized, meaning it's only in one area, and when the size of DCIS relative to the size of breast allows clear margins to be achieved while maintaining an acceptable cosmetic result. Option 2, mastectomy. A mastectomy removes all of the breast tissue. It is considered when DCIS is extensive, meaning it's covering a large area of the breast. Also, when the DCIS is in multiple areas simultaneously, or when clear margins cannot be reliably achieved with lumpectomy. After mastectomy for DCIS, radiation is generally not required. Reconstruction can be discussed at a time of mastectomy planning, either immediate reconstruction at the same time as the operation, or delayed reconstruction at a later date. Some women with low-grade, limited DCIS may choose mastectomy for personal reasons, to reduce anxiety, avoid radiation, or because surveillance after lumpectomy feels unmanageable for them. It's a valid choice. It's not better or worse than lumpectomy from a survival standpoint. Long-term outcomes are exactly the same. It's a different balance of trade-offs. Breast reconstruction in New Zealand after mastectomy for DCIS is publicly funded, although waiting time for reconstruction may vary. So discuss these options with your surgeon at the first appointment, including implant-based reconstruction, tissue-based reconstruction, and timing of each. Option 3, active surveillance. As I covered in video 2, active surveillance, which means watching closely without immediate surgery, is an emerging option for carefully selected women with low or intermediate grade small volume DCIS. It is still largely within the context of clinical trials, and the COMET trial data at 2 years is encouraging, but not yet sufficient to make this a standard practice. So if you have a low-grade DCIS and you want to explore this option, it is absolutely reasonable to ask your surgeon directly, am I a candidate for active surveillance? And is this something you can offer or refer me to a trial for? If you're told no without any explanation, it is reasonable to ask why and to consider a second opinion at a center with active involvement in DCIS research or treatment. This is a section I want you to screenshot, write down, or come back to before every appointment. If you'd like this to be emailed to you, please click on the link below. These are the questions that will make every clinical conversation more useful. Step 1. Before your first surgical appointment, bring a copy of your biopsy report if you have it. Bring a list of any medications you take, including supplements and herbal remedies, because some affect surgical risk and anesthetic. Bring your support person. Bring something to write with or ask permission to record conversation on your phone. Questions for your surgeon, and write these down. 1. What is my grade and what does that mean for my specific risk progression? 2. What is the size and extent of my DCIS, and is it in one area or multiple areas? 3. Is lumpectomy feasible for my situation, or are you recommending mastectomy, and why? 4. If I have a lumpectomy, will I need radiation, and what does that involve practically? 5. Have you considered active surveillance for my case, and if not, why not? 6. What is the risk of recurrence with the treatment you're recommending, and what would recurrence look like? 7. Do I need any further imaging before surgery, an MRI, or additional views of mammogram? 8. What is the timeline from now to surgery, and what are the steps between? 9. Is there anything about my case that is unusual or that I should make sure the next doctor I see knows about? Questions for your radiation oncologist, if these are relevant. 1. How many sessions of radiation will I need and over what period of time? 2. Where will treatment be delivered and what are the logistics? 3. What are the side effects, short-term and long-term, and how are they managed? 4. Is partial breast irradiation or hypofractionated radiation an option for my situation? A second opinion is always appropriate for DCIS diagnosis. It will not offend your surgeon and is part of informed consent. When seeking a second opinion, ask surgical rooms to transfer your imaging to your surgeon's practice and bring your biopsy report. In New Zealand, you can request a second surgical opinion through the public system, although waiting times may vary. Private breast surgery appointments can be often arranged within 1 to 2 weeks. Let's talk about what comes after surgery, because this is often the part that is least well explained and where many women feel most uncertain. Lumpectomy for DCIS is typically a day procedure or overnight stay, depending on the timing of your surgery or your medical problems, or maybe where you've had your surgery done. Most women can go home the same day. You will have just a wound dressing. Your surgeon will advise on wound care. The final pathology report from that excised tissue, not just biopsy, in Wellington takes about 2 to 3 weeks. This report is critical because it confirms the grade, the size, and whether the margins are clear. Clear margin, meaning DCIS is not at the edge of what was removed. In Wellington, we aim for 2 millimeters and more, mean surgery was complete. If margins are involved, a further operation called re-excision or a completion mastectomy may be needed to remove more tissue. Most women are back to light activities within 1 to 2 weeks. Heavy lifting and strenuous exercise are usually restricted for 4 to 6 weeks, and you probably will not feel like doing any of those. And your surgeon should give you a specific guidance. After lumpectomy, you will commonly be referred to radiation oncologist. And if radiation is recommended, it usually starts around 6 weeks after surgery, once the wound has healed. In New Zealand, all DCIS cases are discussed at multidisciplinary meeting, and recommendation for adjuvant treatment like radiation is decided during those meetings. Mastectomy is a large operation, typically requiring 1 to more nights in hospital, depending on whether reconstruction is performed at the same time and what type of reconstruction. Your recovery time is generally 3 to 6 weeks before returning to work, sometimes even longer if you have physical roles. If you have had immediate reconstruction, your recovery pathway will include follow-up with both your breast surgeon and possibly plastic or reconstructive surgeon. After mastectomy for DCIS, radiation is generally not required, and you will not need mammograms on the treated side. The remaining breast, if mastectomy was done only on one side, will continue to have annual mammographic surveillance. After lumpectomy and radiation for DCIS, you will be placed on a surveillance program. In New Zealand and Australia, this typically involves annual mammography of both breasts. You will have a follow-up appointment with your surgeon, typically 2 to 3 weeks post-surgery, then annually for 5 years. After 5 years of clear surveillance, most women will return to yearly screening mammograms for 10 years after surgery, and some of these may be done in a breast screening setting. After treatment for DCIS, contact your surgeon promptly if you notice a new lump in the treated breast or the other breast, skin changes, redness, dimpling or puckering over the treated area or any other areas, new nipple discharge, or unexplained swelling or pain that develops after your initial recovery period. And most of these will have benign explanation: scar tissue, fat necrosis from surgery or radiation, skin changes. But they should always be assessed. Do not wait for your next scheduled appointment if something feels new or wrong. I want to acknowledge something that doesn't always get enough airtime in surgical consultations. A DCIS diagnosis, even though it carries an excellent prognosis, is psychologically significant. the word cancer has been used. Treatment is happening. Your body has changed. And for many women, the surveillance that follows, knowing that every mammogram will bring a level of anxiety, becomes part of life in a way it wasn't before. And that's completely normal. It's not weakness. And it is worth raising with your GP if this anxiety is affecting your day-to-day life. The Cancer Society in New Zealand and the Breast Cancer Network Australia both have support services, helplines, peer support, and resources specifically for people with a breast cancer diagnosis, which includes DCIS. I want to leave you with a few things before you go. Most importantly, you can do this. A DCIS diagnosis is frightening and disorientating, but you now have more information than most women get in their first surgical appointment. You know what questions to ask. You know what to expect. And you know your rights in this process. Second most important thing to know is you have time. DCIS is not a medical emergency. The decisions ahead of you are important, but they do not need to be made in panic. Take the time to understand your options. Thirdly, you're not alone. This diagnosis is more common than most people realize. Around 50,000 to 60,000 women are diagnosed with DCIS every year in US alone, and in New Zealand around 350 to 500 cases per year. There are communities, there are resources, and there are clinicians who will take this seriously and will treat your questions with respect. And one more thing before I go. I'm so frustrated with DCIS. Not with the women who have it. Never that. I'm frustrated with DCIS as a disease, with its name, extent, and treatment. The mortality from DCIS has not dropped in proportion to the dramatic rise in cases we are finding and treating. And that should give us a pause. Not a panic, a pause. In my next video, I'm going to go deeper into exactly that question. Subscribe so you don't miss it. And in the meantime, you have your roadmap, you have your questions, so go into your appointment knowing you deserve a real conversation, not just a protocol, because you do.